I'd just like to begin by acknowledging that we are meeting on the lands of many traditional owners, and I pay my respects to elders past and present and to any First Nations people who are joining us today. So thank you all for attending, and today's presentation is brought to you by the Holsworth Research Initiative, which is funded by the Holsworths, and I saw that Bill was online today, so hi Bill, thank you for showing up. And is also part of the Trobe Rural Health School research seminar series. For those who don't know, Dr. Lavie is a professor of medicine and medical director, cardiac rehabilitation and preventative cardiology at the John Ochsner Heart and Valve Institute at the University of Queensland School of Medicine, New Orleans. He's the author of over 1,500 medical publications, including 2 textbooks and nearly 60 book chapters. So, very much tip for showing up, and yeah, good luck.
All right, thank you, Daniel, and I appreciate the opportunity to give this presentation on one of my favorite topics. As you mentioned, I have my disclosures here, really nothing that's very applicable for this lecture. I was very privileged several years ago when Valentin Fuster, many people consider him the top cardiologist in the world, he asked me to lead the Promoting Physical Activity and Exercise paper for his Jack Health Promotion series that became a very big series, and this paper was also very well received and heavily cited. I've actually been editor-in-chief since 2014 of Progress in Cardiovascular Diseases, and I've had a couple of big issues on physical activity, exercise, and fitness. This is one that I did with Ulrich Wisloff from Norway, from Trondheim, and it was a very successful issue. This is a paper by Wen and colleagues. It was a very, very big paper that came out in 2011, 450,000 from Taiwan, and really makes the case that as you increase your age, it really didn't matter much until about age 60, but particularly in your 60s and you got over 70, the difference between survival between those with low, medium, and high physical activity, the differences are becoming much more marked as time goes by. When this paper first came out in 2011 in Lancet, and I'll get to this toward the end, the headlines in our newspapers was that all you had to do was 15 minutes of exercise to get a mortality benefit. And people loved to hear that all you had to do was 15 minutes. But we'll get to the dosing toward the end. There's been many papers, and this is one by one of my friends, Peter Kokonos, many years ago, 15 years ago in Circulation, showing that fitness, cardiorespiratory fitness, basically the time and speed and incline that you go on a treadmill and you have algorithms to estimate the METs, that the more fit you were, the higher your METs were, the better was your survival. And back in the late 2000s, it was actually said that once you got to 10 METs, you kind of had maximized out. It didn't really, it was if you got a higher number of METs, your survival didn't go up very much. Well, now we know that's not the case. There's papers that show that even when you get up to 17 METs, 19 METs is a little bit better than 17 METs as far as survival. But the slope of the line is much lower, and so you don't get as much bang for the buck as you start increasing the METs to super high levels. But the data certainly supports that fitness is more important than even physical activity. And this is a very big paper that was in JAMA, really heavily quoted by Kodama and colleagues in 2009, of 33 studies, 103,000 people with a lot of deaths to play with, really showed that fitness was very much associated with survival. For every one estimated MET change, mortality and cardiovascular disease, coronary heart disease events were affected in this study by 13 and 15% respectively. Now, just in the last couple of months, Jari Luukkonen from Finland did a bigger meta-analysis now of 2.3 million, 37 studies, 2.3 million people that really showed that for every one estimated MET, there was about a 11% change in mortality, and showed that the top tertile of estimated METs had nearly a 50% better survival than those in the lowest tertile. And I was very privileged to write the editorial for this paper in the Mayo Clinic Proceedings. And just in the last 2 weeks, Peter Kokonos has a major study that came out from the VA cohort of 750,000, all at his VA center. And with over 10 years of follow-up during this time, they had 175,000 deaths. So a lot of statistical power. They showed in this paper that fitness was a very important predictive survival across ages, across races, across genders, both equally in men and women, and showed in this paper that as you got to about 14 METs, you maximized out your survival in this cohort, and those who got to 14 METs typically had men had 6 years longer survival, women had 6.7 years longer survival compared to those with lower levels of fitness. And again, showing that that those in the high levels of fitness had in the highest quintile of fitness had nearly an 80% lower mortality compared to those in the lower fitness levels. So I was also very fortunate to write the editorial for this paper for JACC, which is one of our leading clinical cardiovascular journals. I really made the point in this editorial that that probably in the United States, the group that this is most applicable to is our African American population, because they have higher obesity, they have lower levels of fitness, they respond less to exercise training. So they a group that really are going to need to focus on fitness to improve their health in the upcoming decades. These are quotes that I've seen many years ago. Cicero said, exercise and temperance can preserve something of our strength in old age. The philosopher Socrates said, it is not bodily habits spoiled by rest and illness, but preserved for a long time by motion and exercise. The Earl of Derby said, those who think they have not time for bodily exercise will sooner or later have to find time for illness. And the famous clinician, Paul Dudley White, said, healthy exercise is valuable not only for the maintenance of good physiologic functions of the body, but also mental clarity and feelings of good health. Well, if this is all true, then why do we hear so often that people need to get the okay from their physician to begin an exercise program? It seems to me that we should have a warning before beginning a program of sedentary living and isolation from the natural world. We should be seeing your physician, you don't need to see your physician to start an exercise program. Now, many years ago, in the early 2010-11, the Lancet had a physical activity whole series. And in this series, one of the papers showed that 6 to 10% of NCDs worldwide is attributable to physical inactivity, somewhere between 6 and 10% for coronary disease, 7% for diabetes, 10% for breast cancer, 10% for colon cancer, 9% for premature mortality, was statistically at least attributable to physical inactivity. And they suggested in this paper that 5.3 million deaths per year worldwide, based on the 2008 death rates, the paper came out in the early 2010 or 11, could be avoided if we completely eliminated physical inactivity. And if you only decrease physical inactivity by 25%, you'd avoid 1.3 million deaths worldwide, and by 10%, over 500,000 deaths worldwide. So pretty profound overall effect that we could accomplish by lessening physical inactivity. Now, I'm also the author of the book, The Obesity Paradox, and I'm going to talk about some of this in this presentation, particularly the importance of physical activity and fitness in the obesity paradox. But before doing so, I'd like to mention that Valentin Fusa also asked me to head his healthy weight and obesity prevention article for this health promotion series. And this one has also been very heavily cited. Now, we know that obesity is in epidemic proportions and worldwide. And we particularly have a problem in the United States, I think more so than y'all do in Australia. I think many people blame the obesity epidemic on the fast foods, on the sugary beverages, particularly, blaming it on Coca-Cola, Pepsi-Cola, blaming it on Burger King and Taco Bell and McDonald's. But my colleagues and I really believe that the fundamental cause of obesity is probably, although these factors matter too, but the fundamental cause is the marked decline in physical activity that's occurred over many decades. Ed Archer and I published a paper in PLOS One about a decade ago, and this paper got a lot of publicity. We've measured 5-decade trends in women's use of time, household management, energy expenditure. Basically, what we measured was housework in women. And this paper got a lot of publicity, and it wasn't all good publicity. And I'll just give you an example. When the paper came out, there was a picture of me in one of the leading newspapers in the United States that had a caption that said, "Women are getting fat because they're not doing enough housework." You can imagine how well this went over on the home front. My daughter came home. She was a medical student at the time and told me that my sister, who was a social worker at the charity hospital in New Orleans, was very upset about my paper. And this paper was on many of the talk shows, and a lot of them, made jokes about it. But what we basically showed in this paper, that over 5 decades, there was marked decline in the energy expenditure that was attributable to housework in women, more so in women who were unemployed than employed. But basically on the idea that it's about 1,800 calories on average per week. And if you use the simple formula, this is a really rough estimate, but basically if we use the formula that 100 calories are burned for every mile traveled by foot, this data would suggest that the average woman today would have to walk or jog 18 more miles per week to make up for the housework that's not being done today that was being done 5 decades earlier. That's a lot of exercise. And somebody asked me in an interview, what did we measure housework in men? And I said, are you kidding me? Men don't do housework. No, actually, I know men do housework now, but certainly there wouldn't have been many men 5 decades ago that was doing a lot of housework. But my colleagues did measure occupational physical activity and basically showed that for both men and women, marked declines over 5 decades in physical activity at the job site. And when they plugged this data into the increasing prevalence of obesity, it almost completely tracked with the increased prevalence of obesity that we were noting in the United States. Now, more recently, we had papers on the physical activity over many decades in mothers. And we showed, as you'd obviously expect, that sedentary time is increasing and physical activity time is decreasing. This is in women with children over the age of 5. But for women with children under age 5, the differences are even more pronounced, with bigger declines in activity time and bigger increases in sedentary time. And again, when you plug this into the formula, you find that the women with young children are actually burning about 1,500 calories less per week compared to decades earlier. And the women with a little bit older children, it's more like 1,300 calories per week. But that's a lot of physical activity. And this probably is playing a role in the increasing obesity in the women in our society. But it also probably, because there's a lot of evidence that the hand who rocks the cradle rules the health of the next generation, it's probably affecting the kids as well and increasing the obesity in the whole society. Not to mention that physical activity is one of the main things that predicts cardiorespiratory fitness. It certainly is a genetic component of fitness, but the main thing that contributes to fitness is physical activity. And so not only is this affecting the calories being burned, it is probably also affecting the cardiorespiratory fitness levels of women over time. Question is, how does physical activity, exercise, and fitness protect the individual from cardiovascular disease? There are many things on this slide. Autonomic nervous system, heart rate variability, affects blood pressure, endothelial function. It affects the platelets. It certainly has effects on the mitochondria, and improves systemic inflammation, improves insulin sensitivity. One thing that we believe that's been neglected in a lot of medicine is the effect of physical activity on mood and psychological stress. That this has certainly been neglected, I think, in most medical fields, and the same is true in the field of cardiovascular disease. There's tremendous evidence that stress is a risk factor for cardiovascular disease, and it affects recovery following major cardiovascular disease events. And as Cicero noted centuries ago, it is exercise alone that supports the spirit and keeps the mind in vigor. I did a major review for the Canadian Journal of Cardiology several years ago where we reviewed all of mostly our data that we had published over 2 decades on the benefits of cardiac rehabilitation and exercise training to improve fitness and psychological risk factors and the effect that this had on their subsequent mortality. Again, published in 2016 in the Canadian Journal of Cardiology. One of our earlier papers, now getting close to 20 years ago, was in the Archives of Internal Medicine. This is now called JAMA Internal Medicine, where we showed a very high prevalence of psychological distress in our cardiac patients. High depression, high anxiety, high hostility, or another way to say this is unexpressed anger. A little bit higher in the younger patients. We defined younger in this study as under 55, and we defined elderly as over 70. But it was pretty much depression was high in both the younger and older. Anxiety and hostility were much higher in the younger compared to the older individuals. But following a cardiac rehabilitation and exercise training program, we showed that anxiety fell by 30 to 40% in the older and fell by like 70% in our younger patients. Hostility or unexpressed anger fell by about 60% in both the older and younger patients. Again, it probably was more important in the younger because of the higher prevalence. And the thing that's probably the most important for predicting prognosis is depression. And depression fell by 70% in the older patients and almost 80% in our younger patients following a cardiac rehabilitation and exercise training program. In a subsequent paper, we studied close to 600 patients, followed for 3 years, and showed that the patients who were depressed following cardiac rehabilitation had 4 to 5 times higher 3-year mortality compared to those who were not depressed. And when we compared the controlled depressed versus the active depressed, and the active depressed were those patients who met criteria for depression, but who did the cardiac rehabilitation and exercise training program. And the controlled depressed were those who met all the criteria to enter the program, but who didn't enter the program. And the controlled depressed during the next 3 years had over 3 times higher mortality when everything else was similar on paper compared to the active depressed. Now, granted, this was not randomized because cardiac rehabilitation has been indicated in the United States for several decades. And on paper, although they look the same as the active depressed, certainly one could say that the patients who decided not to enter cardiac rehab may have some intrinsic differences compared to those who decided to enter and complete a cardiac rehabilitation exercise training program. Also, cardiac rehabilitation is not just exercise. Exercise is probably the major component, but it's also a lot of education, a lot of support. We have group sessions, kind of like psychiatrists do with group meetings. So we tried to determine, what was it? Was it the exercise or was it the other components? And one of the ways we tried to do this is by looking at the change in cardiorespiratory fitness. We actually measured gas exchange by cardiopulmonary stress testing in all of these patients. And we showed in this study, now 15 years old, that those who didn't improve their peak VO2 continued to have a very high prevalence of depression and a high mortality risk during the next 3 years. Whereas that those who got just a little bit of improvement in peak VO2, meaning anywhere from 0% to 10%, or if they got higher than 10% improvement in peak VO2, that they had big reductions in their depression and big reductions in their mortality risk. Now, in this paper, we suggested that you got all of the benefit from just a little bit improvement in peak VO2. In other papers that are much larger, we're showing that even more improvement in peak VO2 was better. But certainly this data suggests that you get a lot of benefit with just even small improvements in your peak oxygen consumption. In a more recent paper of 1,171 coronary patients followed on average for 7 years, we showed, unfortunately, that in our cardiac rehabilitation and exercise training program, 23% of our patients did not improve their peak VO2 by cardiopulmonary stress testing. And when we were writing up this paper, we realized that there was a paper of about 200 patients by Patrick Savage from the University of Vermont over a decade earlier, that they didn't look at survival, but they showed in their paper that almost the exact same 23% did not improve their peak VO2 with a cardiac rehabilitation and exercise training program. But we showed in this study, published in the European Heart Journal, that those who got high improvements in their peak VO2 had by far the best survival. Those who were non-responders had the highest mortality, and those who had an intermediate response had an intermediate mortality during the next 7 years. Now, this is measuring peak VO2 by gas exchange. In an abstract, we actually looked at those, not only the gas exchange, but we looked at the estimated METs. The estimated METs is different than the peak VO2. Estimated METs is estimating the exercise capacity based on how most of the world does so, based on the speed and incline of the treadmill. And we showed the best survival with those who improved both their peak VO2 and their estimated METs. The worst survival were those who didn't improve either. And if they improved one versus the other, there was an intermediate survival during the next 7 years. And a more recent paper from this cohort, also in the European Heart Journal, we studied 853 patients who were followed on average for close to 7 years, and showed in this paper that the end peak VO2 was the strongest predictor of survival in our coronary heart disease population. And we also showed in this paper that if you got a peak VO2 over 17.6 cc's of oxygen per kilogram per minute, this may not be super for athletes, but this would be a pretty good peak VO2 for coronary heart disease patients, that you had overall a quite good survival during the next 7 years. Now, there's substantial data that shows it's not just fitness that we're concerned about, but what we are really concerned about is low fitness. Certainly, if we could get people out of the lowest fitness quintile and get them all the way up to the highest fitness level, we would have the most profound effects. But if you notice from this slide, the biggest bang for the buck is just getting people out of the low into the next low, or maybe in the middle fitness levels. You still get further and further benefit if you get even higher fitness. But the biggest bang for the buck is getting people out of the low fitness level. And you can really do this by just getting the physical activity guidelines, getting 150 to 300 minutes per week of moderate physical activity, or getting 75 minutes per week of more intense physical activity. Now, I've been involved with Ulrich Wislov's group, where we've developed, and actually Ulrich Wislof was the one that developed a personalized activity intelligence, a PI. And we published the first paper on this back in 2016 in the American Journal of Medicine, that showed that if you get some of your physical activity at higher heart rates, you got higher levels of PI. And we showed that this was a better predictor of survival than just meeting the physical activity guidelines. It was a better predictor of survival of just getting the number of steps per day. And we published the first paper on a cohort from Norway. We published papers from using the same PI technology in Progressing Cardiovascular Disease, both in the Aerobic Center, Longitudinal Center from the United States, as well as changes in PI over time in this cohort, again, all showing benefits. And the recent paper that we did in this cohort using PI was in China, of 500,000 people in China, followed for 8.2 years, and again showed that this technology, again, getting at least some of the exercise at higher levels of heart rate, is the best predictor of survival. Now, I've also been a colleague with Peter Schnorr at Copenhagen, from his Copenhagen City Heart Study. And in this paper in the Mayo Clinic Proceedings, we studied several different physical activities. And we interestingly, now again, this is not randomized data, but it looks like from this data that the physical activity that has some social interaction things like playing, tennis, things like playing badminton, soccer, are probably giving better survival than just going to the health club, than just jogging, just swimming, which tends to be non-social things that people are doing on their own. This is just, I think, thought-provoking, but certainly it's not randomized. So it may be that, people who can play tennis and play badminton have skills and have genetics that are different than people who are just joggers. But certainly it suggests that not all physical activity is producing the same survival benefits. Now, I mentioned earlier the obesity paradox. This is a paper in my journal by Von Berry about a decade ago. He evaluated 10 studies that were prospective and objectively measured fitness and BMI and jointly assessed their impact on all-cause mortality. And he showed in this paper that compared to the normal weight fit, the unfit, which was generally defined as the bottom quintile, the bottom quartile, and a couple of the papers, it was the bottom tertile, basically had twice the all-cause mortality, regardless of their BMI. Whereas the overweight fit and the obese fit, those who didn't fall into this bottom level of fitness, had similar survival as did the normal weight fit. And he concluded in this paper then that fitness appeared to be more important than adiposity or weight for long-term mortality. Well, we have assessed this in our cardiovascular disease patients. Paul McCauley and I joined together with the Aerobic Center longitudinal study back a decade ago, published this in the Mayo Clinic Proceedings, of 10,000 men with coronary heart disease who were followed on average for 13 years. And we measured their fitness on the treadmill and defined the unfit as those who fell in the bottom tertile of fitness for their age and gender. And we measured body composition by BMI. We did skin folds for percent body fat, and we did waist circumference for central obesity. And we showed in this paper that those who were relatively fit, now this isn't super levels of fitness, this is just those who didn't fall in the bottom tertile of fitness, they had pretty good survival, regardless of their BMI, waist circumference, or percent body fat. Whereas those who fell in this bottom tertile of fitness, they had much worse survival. But in this group, there was an obesity paradox. In a group that had the low fitness, those who weighed a little bit more, those who had a little bit higher waist circumference, those who had a little bit more body fat, had better survival than those who were thin. And this is for all-cause mortality. And basically, we showed the same thing for cardiovascular disease mortality in this population. A couple of years later, Ross Arena allowed me to use his cardiopulmonary stress testing data bank in a group of patients with systolic heart failure. There was 2,066 patients who had ejection fractions under 40%. The average was in the low 30s. The normal ejection fraction is the squeezability of the heart. The normal ejection fraction is close to 60%, and we usually consider below 50% as being reduced. Well, all of these patients had cardiopulmonary stress tests to assess their fitness level. And we defined low fitness as having a peak VO2 less than 14 cc's of oxygen per kilogram per minute. So for any of you who worked with cardiopulmonary stress testing, you know that 14 cc's of oxygen per kilogram per minute is no super level of fitness. But this is the criteria that Donna Mancini developed 3 decades ago, and it was used heavily 3 decades ago to determine who got transplanted with bad hearts. If you had below a 14, you had a very bad survival. So in this paper, we used the 14 cut point, and we showed that those who got a peak VO2 of 14, again, no super level of fitness, but they had pretty good survival regardless of their BMI. Whereas if they had a peak VO2 less than 14, they had much higher mortality, and there was a strong obesity paradox. We already threw out the underweights because the underweights always have the worst survival. But among those who had low fitness, the best survival was in the BMIs over 30, followed by the overweight, 25 to 30, and the worst survival was in the underweight. I mean, the normal weight, 18.5 to 25. Now, I should say that this is mostly a study of mild obesity because we didn't have many people in this cohort that had class 2 obesity, BMIs above 35, and we had no one with the BMI over 40. And right now, unfortunately, the stats in the United States show that 9% of our adult population have BMIs over 40 right now. That's pretty scary. 1 in 11 adults in the United States have BMIs over 40. In a more recent paper, we assessed physical activity and BMI in the Norway, the Hunt study cohort in 6,500 patients followed on average for 12 and a half years. We showed in this paper that there was a strong obesity paradox. The obese had better survival. But this obesity paradox was only present in those who didn't meet their physical activity requirements. Those who met their physical activity requirements of 150 minutes per week had much better survival, and there was no obesity paradox. Didn't matter what they weighed. Whereas if they didn't meet their physical activity requirements, there was a strong obesity paradox. Those who were a little bit heavier had better survival. And in this cohort, physical activity was a better predictor of survival than was BMI. In a subsequent paper in 2018, we looked at the changes in BMI and changes in physical activity in 3,500 from this Norway coronary heart disease cohort, and showed in this paper that there was no group where weight loss was associated with better survival. In fact, among the normal weight BMIs, those who lost weight had a worse survival, and those who gained weight had a better survival. But a much stronger predictor of survival was maintaining or increasing physical activity, which was much more important than BMI for predicting survival in this population. So what all of these studies of cardiovascular disease patients, I think, just told us was that physical activity and fitness markedly altered a relationship between adiposity or fatness and subsequent survival. Now, back to this Wen paper that was in the Lancet in 2011. Remember, I mentioned the 450,000 Taiwan followed for about 7 years. In this paper, they looked at the dosing. And really, when this paper came out, the headlines in the United States, at least, was that all you had to do was 15 minutes to get a mortality benefit. People love to hear that. That was headlines in our papers. But what this paper showed, though, was that if you looked at the dose, if you did moderate physical activity, it appeared that the more and more you did, the better was your survival. The line starts leveling off a bit at 60 minutes, and it looks like it finally levels off at about 90 minutes. But certainly the more you appear to do, you look like you're getting better survival with moderate physical activity. Well, they defined high physical activity in this paper as only about 7 METs. So that's not a super high level of physical activity. But they showed in this paper that for high physical activity, you start leveling out almost after 30 minutes and certainly by 40 and 50 minutes without further benefit as you increase your vigorous physical activity. Well, we took this same idea and applied it to a running paper that we published in JACC, heavily cited and published in 2014, of 55,000 people followed on average for 15 years. 13,000 were runners and 42,000 were non-runners. And in this paper, we showed that the runners had a 30% lower mortality, and they had a 45% lower cardiovascular mortality. Not a big surprise. Many people would think that running is going to help your survival. But also some people would say, well, if you're able to run, you selected yourself out, maybe it's just associated with better survival. Okay. But when we looked at the dosing, we divided the 13,000 runners into quintiles of dosing. We showed that those in quintile 1, those running less than 6 miles a week, until 10 kilometers a week, those running just 1 or 2 times a week, those running under 50 minutes a week. They got the same mortality benefit and cardiovascular mortality benefit as did those in quintiles 2, 3, and 4, and had a trend for better survival than those in the quintile 5. In a subsequent research letter in the Mayo Clinic Proceedings, we took the quintile 5, the highest quintile runners, and divided them into tertiles. So the highest tertile is then the top 8% of running doses. And we showed in this group, basically this is a group that ran for over 270 minutes per week, who ran 7 times per week, who ran over 30 miles, or that's about 50 kilometers per week. They appeared to lose the benefit. Not worse than non-runners, but worse than those with lower dose running. Now, we certainly lose statistical power as we get to groups that are under 1,000 with wide confidence intervals. So we didn't want to make too much over the toxicity, but it certainly appears that more is not better. And I think this paper raises the possibility that more and more could actually even be worse. Paul Williams and Paul Thompson did a study of 2,400 MI survivors followed for over 10 years and showed, as you expect, those who were more physically active, the more and more physical activity you did, the better was your survival, total mortality and cardiovascular mortality, up to a point, up to about 7.2 med hours per day walked or run. This is the equivalent of about 30 miles running, or 50 kilometers running, or 50 miles walking, which I guess would be about 75, 80 kilometers per week. At this point, you appeared to lose the benefit. Again, not worse than non-exercises, but worse than those doing lower amounts of exercise. Now, I don't think anything magical happens at this point. It doesn't mean like if you go to this point, you get the max benefit, and if you go 1 extra inch, you're going to lose all the benefit. But I think the point is here that there may be a point of diminishing return, and actually a point where you could start losing the benefit from super high levels of exercise. And it suggests then that there may be differences between exercising for health and longevity versus exercising for peak performance. Certainly athletes have to do more and more to win the race, but probably from health benefits occur at much lower levels. And certainly we know that at super high levels of exercise, for example, we had this paper published in Mayo Clinic Proceedings that got a lot of publicity, and I spoke at an Ironman meeting in Hawaii soon after this, and a lot of people were pretty mad at me for having this paper, that where we showed that in this paper that almost a third of people after a marathon, if you do scans of their heart, they have evidence of dysfunction, especially of the right side and the ventricular septum. If you measure their troponin levels, almost a third have increased troponin, and troponin is what we measure in heart attacks. Almost a third have elevated levels of brain natriuretic peptide. That's what we measure to monitor heart failure. So there are some negative effects that occur, at least acutely, with very, very heavy exercise. Fortunately, not many people get permanent damage from this. But this is on the same line that we just published in the Mayo Clinic Proceedings from 8,700 from the Copenhagen study, where we showed in this paper that the sweet spot for sports activities was in the range of 2.5 to 4.5 hours per week, whereas those who were doing sports activities for over 10 hours per week actually appeared to lose the benefit and had a slightly higher mortality than those who were exercising 2.5 to 4.5 hours per week. Now, again, none of this kind of data is going to be randomized, but once again, it certainly suggests that if you're exercising for health, you can get the benefits at much lower levels. And as Hippocrates said centuries ago, if we could give every individual the right amount of nourishment and exercise, not too little, but also not too much, would have found the safest way to health. And as most of you know, there was physical activity guidelines that came out in 2018 that these basically suggest that All adults should be doing 150 to 300 minutes per week of moderate physical activity or 75 minutes per week of vigorous physical activity. In the old guidelines, it suggested that you had to do exercise for at least 10-minute bouts for it to count. Now, the guidelines are saying every exercise counts. So if you just go exercise for 30 seconds or 1 minute, you walk up a couple of flights of stairs, it all adds up for your benefit. Also, it suggests that adults should do 2 or more sessions per week of resistance exercise. We have a major paper in MSSE that showed that just 1 or 2 resistance exercise sessions per week gave mortality benefits and cardiovascular mortality benefits above and beyond cardiorespiratory fitness. The recommendations say that older adults over age 80 should also do balance training, and certainly in the older adults, it may be that resistance exercise, muscular strength training may be even more important than aerobic exercise. The recommendations are kids should be active throughout the day between ages 3 to 5, and between ages 6 to 17, they should be doing 60 minutes per day of moderate or to vigorous physical activity on most days. Now, we know we've been in a COVID environment. This is a paper that came out in our Mayo Clinic proceedings from our Detroit group, a small group of 246 individuals who showed up with COVID. And they showed in this paper that those who were more fit had less hospitalizations. Those who had a fitness test prior to developing COVID had less hospitalizations during COVID. And basically, for every 1 met higher fitness, there was actually a 15% lower hospitalization rate. And when they corrected for baseline factors, it was 13%. I was fortunate to write the editorial for this, saying that fit is it in COVID-19, future pandemics, and overall healthy living. And my friend Robert Salas out in Kaiser did a study. Actually almost got this published in JAMA, but it was published in a very top journal, British Journal of Sports Medicine, of 50,000 people in Kaiser who had physical activity assessment and then developed COVID, and showed that those who met their physical activity requirements, over 150 minutes per week, had much lower rates of hospitalization, had much lower rates of needing to be admitted to the ICU or being put on a ventilator, or death. So all of these data supporting that physical activity and fitness are very important for protecting against COVID, and probably that's the case for other pandemics as well. Ross Arena and I were instrumental in forming an organization that's worldwide now called Healthy Living for Pandemic Event Protection. It's called HL Pivot, that we've been doing a lot of work with various organizations around the world, a multifactorial approach to try to improve the health of our populations for future pandemics. We had an article in the Progress in Cardiovascular Disease describing how right when COVID was hitting, it was basically 2 pandemics colliding, the COVID pandemic and the physical inactivity pandemic. And this has actually led to, the COVID certainly led to further physical inactivity and sedentary lifestyle in our society. This also plays a role, physical activity plays a role in immunity and your response to infection. So there's a lot of potential benefits. Our older population, I think, has been most affected by this because they probably quarantine the most. We have a couple articles showing how this has really affected the older population. Physical activity promotion is something that we need to do throughout the healthcare system. We have not done a good job. I think all of us in the exercise field have not done enough to promote physical activity. And this certainly is the case in our medical practices, but I think all the field of exercise, we've done a lot with the science, but we haven't done enough to promote the importance of physical activity, exercise, and fitness throughout the healthcare system, throughout all of society. We are suggesting that every visit to the clinician, there should be a question about physical activity, and there should be a recommendation for physical activity, and it should be actually written in the medical record. So in conclusion, our 2018 federal guidelines suggest 150 to 300 minutes per week of moderate physical activity at 75 minutes per week of vigorous physical activity, and 2 to 3 times a week of resistance exercise. And probably just one might be enough. Recent evidence, though, suggests that benefits of exercise occur at levels well below this. We certainly know with our running study, the maximum benefits appear to occur at very low levels. In almost everyone, the maximal health benefits probably occur at 40 minutes and certainly under 60 minutes. I think promotion of physical activity and exercise training is needed throughout the health system, which can start with exercise and fitness being a vital sign, as Robert Salas has put together at his Kaiser institutions. Improving physical activity, exercise training, and fitness may be particularly needed in the COVID-19 era and beyond. So this is, as a clinician, this is something that I deal with every day. Give it to me straight. The patient saying, give it to me straight, doc. How long do I have to ignore your advice? And then one of the reasons why everyone says they're not doing exercise is that they just don't have time. They're too busy. So the answer is, what fits your busy schedule better? Exercising. I used to have 30 minutes. I used to have 60 minutes. Now I don't know what minutes to put, because I think any exercise is giving some benefit, but exercising at least some per day or being dead 24 hours per day. Thank you again very much, Daniel, for inviting me to do this presentation, and all of you on the line listening. I'll be glad to now take any comments or questions. Thank you very much.
Thank you, Chip. That was great. If anyone has any questions, raise your hand or just speak up and I'll point you out. So anyone have any questions for Chip?
Oh, Dan, I do. You don't mind?
Go for it, Brian.
Thanks, Professor Lavie, for a great presentation. I think we're really lucky to have you kicking us off on a morning here. I hope it's not too late or at a terrible hour for you where you are. I'm a podiatrist and I'm interested in amputation prevention. And recently I've done a study investigating the research priorities of stakeholders involved in diabetes and diabetes-related foot problems. And peripheral neuropathy is a really strong priority for people with diabetes and peripheral neuropathy. And I think it's probably emphasized a little bit. I think perhaps because clinicians think once someone's got peripheral neuropathy, it might be all over. But I do understand that exercise may have a role in possibly treating and reversing peripheral neuropathy. And I'm wondering if you'd have any comments or ideas on that point.
Well, first of all, exercise would be one of the most important ways to prevent diabetes in the first place. Mm-hmm. So more physical activity, more high levels of cardiorespiratory fitness, even resistance exercise actually reduces the development of diabetes in the first place and makes diabetes less severe and improves the prognosis of patients with diabetes. Certainly, if you are physically active, you're going to help prevent peripheral arterial disease, which is part of the leading to amputations. Now, I think the data is stronger for atherosclerosis than it is for neuropathy, but there is some data that it may affect neuropathy as well. Now, on the vice versa, once you develop bad neuropathy, it does limit some of your exercise because you can't do the pounding exercise, maybe on the extremities. But still, even with peripheral neuropathy, there are forms of exercise. Maybe it could be an elliptical machine, maybe it could be a bicycle, maybe it could be water exercise, which could still be tolerated even with pretty significant peripheral neuropathy.
Thank you.
Carol, I see your hand up.
Thanks. Thank you very much for a great presentation. My name's Carol McKinstry. I'm an occupational therapist and actually president of Occupational Therapy Australia. And on your slide around the, I suppose, activity and the difference between, say, for instance, playing tennis or badminton or something like that, what got me thinking was around the meaning of the activity. And as health professionals, as you rightly point out, in terms of our role in encouraging people to, I suppose, lead less sedentary lives, is around really identifying what we would call as occupational therapists, meaningful occupations, and also to establish, routines so that people do fit in exercise or do fit in, more, I suppose, active, meaningful occupations. Your comment?
Yeah, I agree with that, and I think again that I think if somebody asked me what is the best exercise to do, the best exercise is the one that you're going to actually do. So it could be way different for different people. Telling somebody that they have to do a treadmill if they hate to do the treadmill is not going to work. So if whatever form of exercise, whether it could be a walk, a bicycle, elliptical machine, aerobic dance, yard work, every form of exercise helps. I think the thing about that paper that I showed in the Mayo Clinic proceedings was I was trying to make the point was that psychological factors are a very important part, I think, of the benefits of exercise. And I do think that there may be something to the idea. I mean, I go run every day by myself because it wouldn't be convenient for me to wait for a group to assemble to play basketball with, and from a time and efficiency standpoint. But I do think there's something to say for people who exercise in groups. You know, that group stuff, probably you get some psychological benefits that you don't get maybe just exercising all on your own.
Yeah, the social connectedness, and I think you can't let the team down. So I'm thinking about particularly perhaps, interspersing the regular activity, but with also, activity that does expose you to perhaps more social connectedness. Thank you.
Thank you.
Hi, my name is Lisa Hanson. I'm a physio interested in cardiac rehab here in Bendigo. Thank you for your presentation. It was really, really incredible. Do you have any thoughts on whether the advice applies across both male and female genders, or do you think that there could be differences with exercise recommendations for women compared with men?
It's typically, I do think that most of the data suggests that the benefits of exercise training are fairly equal in both genders. And in fact, because women may have a lower exercise capacity to begin with, they could theoretically get even more benefit than men who have a higher baseline level of fitness. Now, saying that, we know that, for example, in cardiac rehab in the United States, women are attending less than men, and older women are particularly attending less. And so some people have called for, that we really need to make a better effort and maybe having women-only classes of cardiac rehab. The problem is that it's so hard to accomplish everything. I really think one of the biggest things that we need to do is have more remote cardiac rehab, to where we don't depend on just getting people to the exercise facility, but if they can have their exercise at home or at places that are more convenient, and they don't have to drive or travel to get into the exercise center, I think that's going to be the answer. We have to become a lot more innovative in the next couple of decades to do it with the internet, to do it with smartphones, to do it with fitness apps that we can probably accomplish. And there are small papers that are showing that you get the same benefits on quality of life, psychological risk factors, and fitness with remote as you do with the center-based cardiac rehab. There's no data on that on clinical events that I know of yet, but I do believe that this would translate into clinical events too. It would be nice to see it. The big deal we have in the United States is that it's a challenge to get it all paid for. I do think that probably in Australia, if you have a more prepaid system, you at least may not have that obstacle, but still, there's always going to be obstacles.
Yeah, we certainly face obstacles with distance to travel to programs. Yeah,
because your country's so huge.
Yeah.
So there's so many people that are not going to live close enough to a center.
Yeah.
So you're going to have to do it remotely to reach those people.
Yeah. Yeah.
And in the long run, it's going to save the government money if you can, because cardiac rehabilitation is cost effective.
Oh, absolutely. And I think the demand's going up now that we're seeing people with risk factors and diabetes coming into cardiac rehab programs.
Yeah, and then we really saw how much it was needed in COVID, because at the beginning of COVID, all the cardiac rehabilitation centers in the United States shut down basically for many months.
Yeah.
And then when we opened up in smaller, groups, because we had that social distance and people had to exercise with masks, showing that we really need to be able to go out into the community and have people exercise, at home, in their, on their own, equipment. we have to do a much better job going forward to make cardiac rehabilitation more accessible in the upcoming decades.
Well, we've effectively got a control group here where programs shut down for 12 to 18 months. So we've got people who have had an AMI 18 months ago who haven't had any form of real cardiac rehab.
I think I saw that on TV sometime about in Australia, they've been more nervous about COVID than we are in the United States at times.
Yeah, I think so.
Hopefully y'all are getting more relaxed about
Hopefully.
it after 2.5 years.
It's taken a while, but I think we're there.
Yeah.
Thank you.
Okay, thank you, Lisa.
We should probably wrap it up there just because it's 3 past. But just once again, I'd really like to thank you, Chip, for presenting. Really enjoyed your presentation. Don't want it to end, but we've all got things to do. And I'd also like to acknowledge the Bendigo Tertiary Education Anniversary Foundation and Dr. Bill and Mrs. Carol Holsworth for their support of my position as well as the Holsworth Research Initiative. Without them, this wouldn't occur. So I'd just like to thank them again. And yeah, if anyone's interested in further presentations that we do, we've got our website, the Holsworth Research Initiative. So go and register for it and see other great presentations like Chip's.
Okay, I want this to be on record. Daniel, get to work on those papers.
Yeah, look, I'm just disappointed there's no standing ovation. Chip, where's this?
Yeah, ask Mike Kingsley about how did I get my standing ovation in Perth.
Yeah.
All right, y'all have a great day. Hey, Mike.
How you doing?
I told Daniel earlier about how I got it. I was going to get a standing ovation. You said you're not going to get a standing ovation. I got a standing ovation, and he had to pay. He had to buy dinner and drinks.
Yeah, happily did too, Chip. Have you got a few seconds, Chip, to stay on the line? Is that going to work?
Yeah.
Oh, you're a star. Hey, thank you so much for doing that.
Okay. I enjoyed it, Mike.